You're watching Ketome TV. Knowledge is power. Okay, so I think we are at the point in our chat where it's time to let you share about your topic of choice.
Okay, that's gastric cancer today.
Okay, so what would you like us to know about gastric cancer?
Well, we're going to talk about the causes, talk about some statistics, and then we'll talk about the standard therapy, and we'll talk about a couple of our favorite new approaches.
Okay, all right, go for it.
PD-1 inhibitors.
Okay.
Gastric
cancer 101.
Yes. So there's many different types of gastric cancer.
Okay. Just so I'm clear, because I'm such a layperson when it comes to this side of things, is it fair? Could I call it stomach cancer as well as gastric cancer?
Sure.
Or, it's like those words could be used interchangeably?
Yeah, it depends on whether you're considering the esophagus or the lower stomach and the esophageal junction. There's many different areas. There's a cardia, there's a fundus.
Okay. So gastric covers it all. Stomach is more specific.
Gastrointestinal.
Gastrointestinal.
Yeah, gastrointestinal and gastroesophageal junction.
Oh my goodness. Yeah. Okay. So gastric cancer. We'll stick with that.
I like to call it gastric cancers.
Okay.
Yeah.
Got it.
I'm sure it can be very specific as to the types.
Yeah, I get that. Just as you were saying about breast cancer having many different types.
Yeah, exactly.
Yeah. Okay.
Exactly. So this used to be a deadly disease. I mean, it's still a deadly disease, but it used to be very common in the olden days based on the poor sanitary conditions that food was presented in prior to refrigeration and so on. So
lots of rotten things.
Lots of rotten foods. Yeah, a lot of people died from gastric cancer. And at young ages.
Yeah, and is that we're talking like 1800s, early 1900s?
1900s, yeah, definitely, right up until almost right up until I guess about the 50s is when things started changing.
Not so long ago.
And there's a variety of reasons that we're going to go over that. But what really changed things is a company called Pillsbury, of all things. They worked with NASA because, as you can imagine, an infection in space is deadly. So they worked on creating this protocol for the astronauts that was later adopted by the food industry.
A dietary protocol or a way of preserving
of preserving foods and making sure that the standards of the quality of the food was good and that there were no infections and no contaminants and so on.
Oh.
So that's when things really have changed in the food industry. So Pillsbury and NASA are responsible for that.
Better preservation.
Yeah, exactly. So the causes are basically diet. Poor diet is a huge cause. Obesity is another factor. Untreated Helicobacter pylori, that's one of the major causes. And then there's another cause called autoimmune gastritis. And that's basically where, your immune system kind of attacks your stomach and breaks it down. So the acids break into it.
So the H. pylori, is that the same thing that's ulcer related or no?
Yeah, it is. Yeah, it causes ulcers. So basically your stomach has this mucus layer that protects the cells from the acids, the stomach acids and so on. And there's a lot going on in the stomach. So, I mean, you get vitamins being released there and absorbed. And there's an immune system. It's the first component of your immune system in your digestive tract. So there's a lot of things going on in the stomach, and having that mucosal layer is really, really important. So anything that reduces that mucosal layer, such as Heliobacteria or, any sort of autoimmune conditions, gastro reflux is a big cause, because what happens is the acid goes up into the area of the esophagus that doesn't have a mucus layer, and the acid can cause certain cells to turn into different cells, and that's a cancerous process. So definitely the amount of acid your body requires you to excrete through your lifetime um, uh, bile and stomach acids are carcinogens. So you want to reduce them. And if you're eating a lot of foods that require a lot of digestion and a lot of breakdown,
like heavy
bile,
meat,
heavy meats and so on, things like that can really burn out your. Not only can they burn out your cells that excrete these acids, but they can, having that massive amount of acid, your body is constantly having to deal with it. And if it gets through the mucus layer onto the normal cells, the stomach lining, then it can start causing cancers. So there were some interesting studies done a little while ago, and they found that there's two distinctive trends in gastric cancer in the United States. Based on people being born in the 50s or over age 50. So in people that are over age 50 in the States, gastric cancers, non-cardia type gastric cancers fell by just under 3%, about 2.6% per year, which is fairly good. But for those under the age of 50, there was an increase of about 1.53% a year.
Wow.
More importantly, women tend to get gastric cancer more than men. So what this study did was it looked at a few different variables, and it found, there's a couple of trends here, is that women tend to take more antibiotics than men. For a variety of reasons. And it's believed that the amount of antibiotics you take can increase certain types of stomach cancers by messing up your biota. Yes.
I see.
But then also, if you have H. pylori and you get treated, helicobacteria. If you get treated with that, let's say you have a stomach cancer that's been caused by H. pylori. The interesting thing is getting antibacterial treatment for that particular type of bacteria can greatly reduce the spread of the cancer and creates a lower grade of it. So it's kind of a catch-22. Broad-based antibiotics can mess up the biome, which can reduce the protection of the mucosal layer. We know the biome is involved in protecting and creating the mucosal layer. But also treating it with an antibacteria, if you have H. pylori, can greatly reduce the intensity and the staging of it.
When you say antibacterial treatment, do you mean an antibiotic?
Yes.
Or is that, okay. Right. So really, we need antibiotics, folks, not necessarily all the time, but there are certainly times when...
if you're taking an antibiotic for H. pylori, it's a good thing. If you're taking it for something else, it's not such a good thing.
Well, then you need to obviously back yourself up, right, with some of the things you can do to restore that.
Restore that.
You're probably coming
fiber.
Back to. Are you coming back around to?
Yes, so you restore it. As we know, you restore your bacterial counts, your healthy bacteria counts, lactobacilli and bacteroids that are producing the mucosal layers, maintaining the mucosal layers. You restore them with fiber and probiotics.
Yeah. So it's not a wives' tale. It's an actual thing with some good solid science. Again, go to one of the science sites that you might recommend, like PubMed.
PubMed, there's lots of stuff in PubMed.
And you will see that the combination of fiber with probiotic really does help to restore that healthy biome in the gut. And so women, you need your antibiotics every now and then. We get those UTIs. There's nothing else for it. So don't be scared of that. Just make sure that you follow up with the fiber probiotic combo, reset the balance quickly.
Exactly, yes. So how is it treated? Well, if you have resectable, that means surgically, something that can be surgically removed, gastric cancer, even if it's advanced gastric cancer or gastroesophageal, because it's usually advanced by the time it's diagnosed. There's a couple different chemotherapy combinations. The standard one is called ECF, and then there's also ECX, and that refers to epirubicin, cisplatin, which is a platinum drug, and either 5-fluorouracil, 5-FU, or Xeloda, also known as capecitabine in North America. So that has been the standard for a long time. And then there's a newer chemotherapy combination, which is actually much better, called FLOT, F-L-O-T. And that is fluorouracil, leucovorin, and oxaliplatin, and docetaxel. So it's almost both based on the colon cancer protocols, FOLFOX, but a little different, has docetaxel. And it results in a much better overall survival rate, 50 months versus 35 months for the ECF and ECX. So if your doctor is suggesting the ECF or ECX, I would definitely go with the FLOT, the FLOT. Mm-hmm. Survival at 2 years compared to the previous chemotherapy protocols is 68% versus 59%. Survival at 3 years is 57% versus 48%. And 4 years, I believe it's around 45-46% compared to 36%. So significant difference in just changing the chemotherapy compounds. Mm. So then there's advanced chemotherapy, or advanced treatment. And in that case, it's usually paclitaxel. It's not that effective. So in advanced, when you've already had it and it's come back, and it's recurred and it's treatment resistant now, there's not a lot of options. So we're going to go over a few of those right now. One of the new ones is it's a new combination of drugs that has been very effective in late stage colon cancer. It's called TAS-102. TAS-102 is a drug developed in Japan. It's called trifluridine tipiracil. It's some old chemotherapy drugs that were combined together that target a different part of the DNA than a lot of other chemotherapy drugs do. They target a different groove in the DNA helix. So they seem to work in a different manner, and they seem to work after people have been treated with other chemotherapy regimes. In colon cancers, they can add an extra year, sometimes year and a half. So recently the FDA approved TAS-102 for gastric cancer because it seems to work really well in gastric cancer. Mm. So in very advanced, heavily pretreated patients that really didn't have a lot of options, it almost doubled survival, 5.7 months versus 3.6. Now, typically, this TAS-102 in colon cancer seems to work really well with the VEGF inhibitor Avastin. Mm. And Avastin's been around for a while. So there was some studies a few years ago in colon cancer, and it showed that the TAS-102 as a single agent was almost double the time that people survived on it when you added Avastin to it.
Mm. So up to 10 months or so.
Well, this wasn't done in gastric cancer yet. It was done in colon cancer. So typically in colon cancer, we see up to a year survival rate on average with TAS-102. So it's obviously less than gastric cancer. Mm-hmm. And when you add the Avastin, we see cases where people live 2 years. So it almost doubles the survival rate. Mm. So if I had gastric cancer, I would probably want to add Avastin to the TAS-102.
If you were heavily pretreated late stage?
Yes.
Okay. Yeah. That wouldn't be where you'd start?
No.
Okay.
So number 2 is immunotherapy. Obviously, PD-1 inhibitors are big in every type of cancer. If you are one of the patients that have won the tumor mutation burden lottery, then obviously, this is good. PD-1 inhibitor is going to knock it out of the park for you.
What does that mean, tumor mutation burden?
If you have a high tumor mutation burden, So regardless of the type of cancer you have, with a few exceptions, obviously, if you have a high amount of mutations, or you have what we call microsatellite instability, then PD-1 inhibitors are incredibly effective. And the reason is that it allows immune cells to really differentiate between your normal cells, because there's a lot of antigens and variation between the two based on this high mutation rate.
Okay.
So the FDA has approved PD-1 inhibitors for any type of cancer, literally, with a few exceptions, that has a high tumor mutation burden. So that's one of the first things we check. We call it the treatment lottery. And we've seen some really strange type of cancers. We had a recent case of a neuroendocrine cancer that typically doesn't respond to immunotherapy because they have a very small amount of mutations. But in this one particular patient, he had a massive amount of mutations, and we got him on immunotherapy, and he's just had an incredible response to it so far.
So that's the lottery. If you have that high tumor mutation burden.
So if you don't have that high tumor mutation burden, then your level of PD-1 ligands, it's a PD-1 test stain, can determine whether you are going to respond to these drugs or not.
Okay.
So they call that the CPS.
Okay.
So if you have a PD-L1 CPS of 1 or more, then your overall survival is not that much different. In fact, chemotherapy is slightly better, and that's with gastroesophageal junction or gastric cancer. However, if you have a 10 or more, it doubles the survival. In fact, patients are getting like 17, 18-month survival rates versus, about 10 for standard chemotherapy.
Okay, so between 1 and 9, probably not so great. 10 plus.
10 plus, yes.
Double survival.
Yes, yeah. And in people with 10 plus, 2-year overall survival rate was 39% versus 22% for chemotherapy. So, it's almost a doubling of survival.
That's great.
Survival rates and so on. So some people with gastric cancer have what's called HER2 positive gastric cancer. And that would be the consolidation prize of the lottery. It's not quite as good as having a high tumor mutation burden, but it means that you can now be treated with a whole class of what we call HER2 targeted therapies. And HER2 is, as you probably recall, is a type of breast cancer, HER2 positive breast cancer. So a lot of the drugs that have been developed for breast cancer, HER2 positive breast cancer, have also been transferred down to gastric cancer. One of them is called trastuzumab deruxtecan.
Is there a short version for this?
Not this one.
Oh gosh. Okay, let's try it one more time then, so people at home can write it down.
Trastuzumab deruxtecan.
Thank you. Well done.
It's a HER2 targeted drug. Basically referred to as Herceptin. It's a monoclonal antibody. However, it has a chemotherapy drug attached to it. So it's called antibody drug conjugate. And it has this topoisomerase 1 inhibitor, deruxtecan, attached to it. So in that particular drug, patients with late stage, the overall response rate was 43.2%, which is really good. And the progression-free survival, median progression-free survival was 7 months. It's a relatively new trial, so we don't have overall survival data yet.
Okay.
So once again, as I mentioned earlier, gastric cancers can respond to VEGF inhibitors or targeting of the angiogenesis pathway. Angiogenesis is the tumor-initiated recruitment of blood vessels. As tumors grow and metastasize, they need a lot of blood. So there's targets to the process on the 7 different steps 7 or 8 different steps actually involved in angiogenesis. And there's many different proteins. One of the proteins is called VEGF, vascular endothelial growth factor receptor, and ligands. And there's a few different drugs. Avastin, as I mentioned earlier, is one of them. It inhibits VEGF, but there's a new class now that target VEGF receptor 2. And they target the extracellular domain, the monoclonal antibodies. And so what they do is they target the outside component of the VEGF receptor.
Okay.
One of the drugs is called ramucirumab. In a recent basket study, they combined it with pembrolizumab in late-stage gastric cancer patients. And the overall response rate was not the greatest. It was 7%, but these are fairly advanced patients. But 44% of these patients had stable disease. So in other words, the tumors did not grow or shrink.
Oh, well, that's not bad. Is that late? You said that was late stage?
Yeah, late stage.
Wow.
Yeah.
Okay.
So late stage gastric cancer is a tough one to treat. There hasn't been a lot of developments until recently. I think most of the developments are going to be in these immune-based combinations, and having immune activators that are going to help benefit patients that have low PD-1 expression and low tumor mutation burden.
Yeah, that's good. And as you were saying, if you have the HER2 mutation or the PD-1, I mean, there's quite a few different potential mutations that can really change the type of treatment that's going to be right for you and the overall survival rate.
Exactly.
Even for late stage cancers.
Yes.
Well, that's good news.
Yeah. So that pretty well wraps it up for gastric cancers.
Okay, so there are new options, doubling survival at least once you know what your mutations are, is the big takeaway for me. Plus, certain self-care processes like making sure your gut biome is healthy with the fiber probiotic combo.
Yeah, avoiding meats.
A few other things that you can do for yourself independent of your doctor that have some good medical proof behind them to be really beneficial, so you don't have to get experimental with your life and your health and your cancer care. And it's really important not to, in fact, because there's so many really excellent options right now out there. Okay, thank you, Alex. That's, I'm not going to remember the name of some of those drugs, but you guys can press rewind, watch again, and then always make sure. I mean, Alex gets all of his data from FDA-approved tests and treatments, peer-reviewed medical science journals only. But we want you to have confidence in what you're doing. So if you're going to take some of this information to your doctor, stop first, go onto PubMed online, do some research, and just give yourself just even 20 minutes to have a look at a few different studies, get a little more confident, a little bit more comfortable about the data that's out there, so you don't feel like you're kind of just saying, well, so-and-so said. You really want to have confidence in what you're doing. And if you need assistance in order to have that confidence, because this is all Greek to me half the time, then you can certainly reach out to Alex and his team and have a one-on-one consultation with them. He'll review your medical records, check and see what's gone on already and what can be done based on that. And then he and his team will advise any follow-up testing, just to make sure that your diagnosis is as accurate as it could possibly be and that you're getting the right treatment right from the start. Some of the data that Alex has shared today is talking about people in late stage, extending their lives by 5 months to a year or two, or having some progression-free time that's quite significant. But we want to get you to get on the right stuff before your cancer gets there, if possible, because then there's so much that can be done, and your survival and quality of life can be so much greater. So next week, Alex, you're going to be telling us all about chemotherapy, why chemotherapy fails.
Okay, interesting.
Yeah, and on that note, of course, I'll make sure that Alex talks about what to do instead, or as well as, or making sure that you're on top of that if you did need chemotherapy. We'll make sure that you know what you need to do to make sure you get the most out of it. So we're here every Thursday, 1 o'clock Pacific Standard Time, answering your questions. And if you or anyone you know has cancer or wants to make sure you're doing everything you can for prevention, do join us. Send us your questions on Facebook throughout the week. You can visit Alex's YouTube channel. I mentioned it earlier, but it's called thecancerguy.com. We have hundreds of videos there, 2 to 5 minute snippets about all different types of cancers and things that are really important for you to know about self-care, about prevention, about making sure you get an accurate diagnosis and get the right treatment. So do have a look there. And of course, if you'd like to speak to Alex directly, you can reach out to him through our website at ctoam.com. So thanks very much for joining us. Thank you, Alex. And we'll see you next week.
Bye.
Bye.
Thank you for watching CTOAM TV. Subscribe below and stay informed.